Xin chào tất cả các bạn. Di chứng phổi sau khi mắc COVID-19 là một trong những vấn đề đang được quan tâm trong thời kỳ đại dịch. Những tổn thương về mạch máu và nhu mô đã để lại những di chứng như giảm chức năng hô hấp, phát triển bệnh phổi kẽ cũng như xơ hóa phổi. Hôm nay chúng ta sẽ được bác sĩ Maria Padilla, là giáo sư y khoa của trường y Icahn ở Mount Sinai thuộc thành phố New York, trình bày về vấn đề di chứng phổi của hậu COVID-19. Chúng ta cùng bắt đầu nhé.
Greetings. My name is Maria Padilla, and I'm a professor of medicine at the Icahn School of Medicine at Mount Sinai in New York City. It is my pleasure to be here with you today, and I thank the organizers for inviting me to present on post-COVID lung complications. Here are my faculty disclosures, and here are the objectives of this brief session: to describe the observed complications, to explore potential etiologies, to recognize some of the risk factors, to review management strategies, and to discuss briefly some clinical trials that have been designed to answer many of the questions that have been presented by this pandemic. To put it in perspective, let's look at these sobering statistics. More than 48 million cases reported as of November 29, 2021, with 750,000 deaths. Fortunately, a great number of survivors, thanks to all the clinical trials and all the interventions that have occurred at a very accelerated pace. But if only a fraction of these survivors develop lung complications, the problems and the complications are going to be great. What are those pulmonary complications? Certainly symptoms, abnormal physiology, abnormal imaging, and importantly, pulmonary vascular disease and interstitial lung disease. There's been pulmonary arterial hypertension reported with a prevalence of about 8% and in post-COVID infected individual. But by far, pulmonary vascular disease and interstitial lung disease are the major complications post-COVID infection. We know that this is an angiocentric virus, that both macroscopic and microscopic level involvement has been reported. Here we see the microthrombi in the interalveolar septa of a patient who died from COVID-19 infection. And here we see the macro, the hypercoagulability that exists in these patients, and we see a thrombus that is present in this right upper lobe artery. And associated with that is an infarct in the right middle lobe at a different site. There's also evidence that there is some interstitial lung disease. This is occurring at 7 weeks post-acute infection. And by 3 months, the occlusive thrombus has disappeared. But in its wake, we see that there are linear webs that are present in segmental vessels. A hallmark or a typical finding in chronic thromboembolic disease. This is a dreaded complication. But what about the parenchymal lung complications of COVID? Is there ILD post-COVID? Is there fibrosis? Will it impact the functional status and quality of life? We see here that there is an acute pneumonic infiltrate, and by day 99, this has gone on to remodel the lung, and we have evidence of architectural distortion by this time, so that there is a fibrotic event developing here. Who has been able to answer these questions? I think we turn to the literature now, and we see that in this systematic review and meta-analysis of the literature up to January of 2021, So and his colleagues described the persistence of residual CT abnormalities in 56% of the patients. And this was predominantly ground glass opacities, but there were also parenchymal bands and fibrous stripes. This was accompanied by significant PFT abnormalities in about 44% of the studied individuals. And we see here that the most impaired pulmonary function marker was the DLCO at 35% of predicted. Restrictive lung disease was documented in 16%. And importantly, obstructive lung disease was also present in almost 8% of patients who never had obstructive lung disease before. The severity of the disease plays a role in this, and this has been clearly shown by the observational study conducted by the Swiss COVID-19 lung study. And here, severe critical illness was associated with impaired physiologic parameters, but also with radiologic findings. And so hypoattenuated areas were present in a good number of patients. And architectural distortion, a hallmark of fibrosis, is present in 52% of those who had severe COVID. It was also present in those who had mild to moderate disease, as you see here. It's not surprising that the severe patients will have persistent findings, but what is alarming is the finding of restrictive lung disease and abnormal pulmonary function studies in patients who had mild to clinical disease and are remote from the acute infection. So post-COVID pulmonary fibrosis has been described as a non-idiopathic form of pulmonary fibrosis in COVID-19 infected individuals. It has features that are typical or characteristics and has as well as clinical and pathological findings when these are available. It may occur at any time during the course of the illness, in the hospital, during that hospitalization, or in long-term follow-up. To date, we do not know the incidence, the prevalence, or the severity of this entity. But we do know that there are potential pathogenic mechanisms to cause progressive pulmonary fibrosis. These are similar to the pathways that have been implicated in the development of pulmonary fibrosis. And in addition to that, we have the vascular injury that has occurred in these patients, and we have the direct injury from the virus itself. Certainly, the findings of ARDS and barotrauma contribute to the development of fibrotic changes, but there is also a genetic predisposition that will mark some patients as potentially developing interstitial lung disease or pulmonary fibrosis following this injury. There have been some factors that have been associated with progression of the disease, and those are the same factors that have been linked to severe disease. Their lab data, as outlined here, have also been correlated with the post-COVID pulmonary fibrosis. But of interest is the finding that shortened telomeres can also contribute to the pulmonary fibrotic phenotype. And this is a study from a single center with 72 patients who were oxygen dependent and who were followed for 4 months post their discharge. Half of them had required, almost half had required invasive ventilation. When studied, these patients had evidence of fibrotic changes with traction bronchiectasis. They had reticulations, they had ground glass opacities. and about half of them had a reduced DLCO and reduced 6-minute walk distance. The authors found a direct correlation between the SOFA score at admission and the telomere length. The shorter the telomere length, the greater the risk of developing this fibrotic phenotype. So some examples of fibrotic phenotype, and we see here that there are images of patients who have suffered from COVID infection, and we're seeing in follow-up clinic at this time, at initial presentation, which is several weeks post-discharge from the hospital, we see that there is evidence of already what appears to be some fibrotic changes in traction bronchiectasis in this patient who 6 months later has progression or at least no improvement in his function. There is loss of volume and there is increased fibrotic findings at this point. This is accompanied by a loss in forced viral capacity of greater than 10%, certainly a marker for chronic fibrosing lung disease or for progressive fibrosing lung disease. This patient, who had no history of obstructive lung disease, had an initial hospitalization, and where you can see here that there is significant destruction of his parenchyma, the upper lobes, and is accompanied also by ground glass and inflammation at the basis of the lung. By 6 months, the inflammation is gone, but there is residual destruction of lung tissue with emphysematous pockets that remain. This is accompanied by the presence of reticulations and what could be considered early honeycombing, perhaps. But remarkable is the fact that he has a 65% ratio consistent with obstructive lung disease, and that his diffusing capacity is 35% of predicted 6 months after his initial infection. This patient remains on oxygen at this time. So we have seen both destruction of lung as well as fibrotic progressive lung disease. What are the gaps that still remain in our knowledge? What is the prevalence of post-COVID fibrosis? How do we phenotype those patients to determine which patient will develop fibrosis and which will resolve completely their initial injury? Is post-COVID fibrosis a progressive disease, or will it stop at the point of maximal healing? Do antifibrotic agents attenuate the lung function decline in post-COVID fibrosis? We don't know. And are patients who remain with residual fibrotic bands at risk of developing ILD or fibrosis at a future time? We don't know the answers to these questions, but we do know that we have to manage post-COVID lung disease in a systematic way, that we need clinic visits, that we need PFDs, that we need 6-minute walk, we need the imaging that is appropriate for them, and we need an ILD center referral when indicated. The interventions may be limited, but they should be applied, and clinical trials must continue. There are a number of clinical trials that are both observational as well as interventional. Here are 2 observational ones, collecting data and collecting specimens to try to understand this disease better. And we have interventional trials looking at different agents that could potentially have a role to play in slowing down the rate of disease or in preventing the development of fibrotic lung disease. we hope that these can provide the answers that we are seeking. So in conclusion, post-COVID lung complications do exist. And the pulmonary vascular and parenchymal disease are important complications in COVID-19 infection. They are associated with severe disease, but also reported in mild to moderate disease. The knowledge about the manifestations and underlying mechanisms is rapidly evolving, but we do not have final answers at this time. It's appropriate to continue to evaluate and monitor our patients so that we can understand the course of this illness. And it's critical that we continue with the clinical trials, both observational and interventional, in order to provide the final questions, the final answers to the questions, and to guide our management and improve outcomes for all our patients. I thank you very much for your attention and will be happy to entertain questions.
Vâng, bài học đến đây đã kết thúc. Cảm ơn các bạn đã chú ý lắng nghe. Nhớ like, share, subscribe để theo dõi các học tiếp theo nhé. Xin chào và hẹn gặp lại.